Hello and welcome to Knowledge Park. The Female Breast Part 1. Today we look at the female breast, the mammary gland, an amazing, often misunderstood organ of the body. For many, it means femininity and feeding. Under the skin is a smart system of structure and function, facts that guide daily health and medical choices. Whether you are curious, a student, or a clinician, we'll start with the basics and build up to clear, practice-ready insights. We will cover structure, function, how to keep the system healthy, and when to seek help. We'll include key points from recent research. So let's begin. First, the architectural blueprint, the surface landmarks and the map beneath. Think of the breast as a well-run factory with one main job: making milk. Many small parts work together to do this. Outside, we see the nipple, the delivery point, surrounded by the lu, the darker circle of skin. This is the factory's front door. The lu has tiny bumps called Montgomery's glands, small oil glands that moisturize and protect the skin. The whole breast sits on the pectoralis major muscle. The breast itself is not a muscle. It rests on that muscle like a cushion on a bench. Cooper's ligaments hold it in place. Think of them as tiny suspension bridges that shape and support the breast. Inside is the working core, the glandular tissue. There are about 15 to 20 lobes, arranged like flower petals. Each lobe has smaller lobules. Inside them are tiny grape-like sacs called alveoli. This is where milk is made. With the terminal ducts, they form the terminal duct lobular unit, or TDLU, the key unit where most normal changes and most tumors begin. From each sinus, a small milk-making sac, thin ducts join together to form bigger channels that carry milk toward the nipple. Small ducts merge into larger ducts, like streams joining a river. The main rivers are the lactiferous ducts. They meet at the nipple to deliver milk. All of this sits in adipose tissue, body fat, which cushions and supports the parts inside. Fat largely sets breast size and softness. Most size differences come from fat, not from the milk-making glands. Around the TDLUS is the stromal neighborhood, fibroblasts, support cells, immune cells like macrophages and lymphocytes, fat cells, blood vessels, and the matrix scaffold. They help the tissue work and send signals. In disease, this neighborhood can shift into a tumor microenvironment, supporting growth, new blood vessels, angiogenesis, and steps toward invasion and spread. Lymphatic drainage goes mainly to the axillary lymph nodes, levels 1 to 2 and 3. Some channels reach the internal mammary and supraclavicular nodes. These pathways matter for staging and surgery. In the clinic, a sentinel lymph node biopsy, or SLNB, uses dye or a radiotracer to find the first draining node, the sentinel. Sampling this node allows focused, less invasive testing. Blood supply comes from key arteries, the internal thoracic, mammary, the lateral thoracic, and the thor kro-me-ul. They support growth, milk-making, and healing. Nerves are rich, especially at the nipple areola complex. They provide sensation and help trigger the milk ejection reflex. Nerves signal hormones to release milk. When a baby latches, touch signals release oxytocin. Myoepithelial squeeze cells contract, and milk flows in a coordinated way. Structure linked to function. This integrated design, from TDLUS and ducts to nerves and lymphatics, explains normal feeding and guides safe, targeted care when problems arise. Keep this map in mind as we go. These details will help you understand symptoms, tests, and treatments with clarity. Clinical map. Breast quadrants, clock face positions, and the Tale of Spence guide notes and imaging. Use consistent sides and clock times during exams. Development and evolution, where breasts come from, how they differ across animals, and the signals that build their support system. In the embryo, a thin line of future breast tissue runs from armpit to groin. This is the milk line, mammary ridge. Most of that line fades away. Usually, 2 small chest buds stay in the breast area. These buds make small inward dips called placodes. They branch. They form the first layouts of the future ducts. Because the whole milk line is a possible site, extra nipples or bits of breast tissue can show up anywhere along it. These are usually harmless. When we map these spots to the milk line, their locations make sense. Most need no treatment unless they bother you. In evolution, skin glands change to feed young. These are the early roots of the mammary gland. Monotremes, like the platypus, have simple branching ducts that open onto the skin. No nipples, milk on skin for the babies to lap. Marsupials have teats and more branching. An in-between design. Placental mammals, like humans and cows, have complex glands made of many tiny sacs and ducts. These ducts meet at the nipple. Side by side, monotreme, marsupial, placental. Same job, feeding young, different designs for different needs. These designs fit each animal's timing, how babies attach, and the type of milk they need. One purpose, many solutions. That is the elegant theme of evolution. Recap. The milk line forms. Most of it fades. Chest buds stay and later grow into breasts. Breast growth usually starts at puberty. This is the start called velar key. It often happens between ages 8 and 13. Early growth is uneven and normal. Sides may not match. Through the teen years, ducts branch and fat increases. Final size depends on genes, hormones, and body weight. Shape usually settles by late teens or early 20s. Tanner stages, 1 prepubertal, 2 breast bud, 3 further enlargement, 4 forms a secondary mound, 5 adult contour, variation is normal. In pregnancy, the glands expand and blood flow rises. Many people go up 1 to 2 cup sizes. Thick first milk called colostrum can appear late in pregnancy. With breastfeeding, breasts feel fuller at first, then settle into a rhythm. After weaning, tissues remodel and often return closer to baseline. Shape may change. Now the key signals. The lining cells and the support tissue talk to each other. That is the setup plan. Epithelium, mesenchyme. A message called PTHRP, parathyroid hormone-related protein, comes from the early lining bud. It tells the support tissue to build strong scaffolds. The support tissue answers back. It guides how the ducts branch. It also shapes the mammary fat pad. Step by step. If this talk goes off track, rare changes can happen. Means a nipple is present, but the gland is absent. Means extra nipples along the old milk line. These are usually harmless. Big idea. Lining cells guide support tissue. Support tissue guides lining branches. A two-way conversation. This teamwork builds the tiny sacs and ducts we need for feeding. Structure serves function. Labels to remember. Milk line. Chest buds. PTHRP signal. Epithelium and mesenchyme talk. Mesia and polythelia, evolution view. Monotreme to marsupial to placental. More complex designs as newborn needs grow. Embryology view. Position is set by the milk line. Shape is set by the talk between lining and support tissue. Advanced note. Gene set timing. Local signals shape branches and tiny sacs, and PTHRP stays central. Parathyroid hormone-related protein, the message from the lining bud to the support tissue. When that talk is disturbed, patterns can shift. That is how the anomalies we named can appear. These ideas guide both anatomy and clinical decisions. Stay calm. Use the map. You now have the origin story, the map and signals that set the stage. Next, we link design to function, how structure supports efficient feeding. Bridge to physiology. Prepare, produce, and deliver. Let's move ahead. Common breast cancer subtypes. These are patterns in the tumor. They help us predict behavior and choose care. Calm, simple tour ahead. Subtypes use 3 receptors: estrogen receptor, progesterone receptor, and human epidermal growth factor receptor 2. These signals guide treatment. Luminal A, estrogen receptor, positive, progesterone receptor positive, and human epidermal growth factor receptor 2 negative. Often slower growing and hormone-driven. It usually responds well to hormone therapy. Luminal B, estrogen receptor, positive and progesterone receptor positive. Sometimes human epidermal growth factor, receptor 2 positive. Compared with luminal A, growth signals are higher. It tends to move faster than luminal A. Your team may add more medicines to control it. Big idea. Luminal B often shows higher grade and faster cell cycle signals than luminal A. Human epidermal growth factor receptor 2 enriched, estrogen receptor negative, progesterone receptor negative, and human epidermal growth factor receptor 2 positive. Human epidermal growth factor receptor 2 is a growth receptor. Targeted anti-human epidermal growth factor receptor 2 drugs have improved outcomes. Example medicines block human epidermal growth factor receptor 2 and slow growth. Modern anti-human epidermal growth factor receptor 2 therapy has transformed care when the tumor tests positive for human epidermal growth factor receptor 2. Triple negative, also called basal-like, estrogen receptor negative, progesterone receptor negative, and human epidermal growth factor receptor 2 negative. It can be more aggressive. It is more common with breast cancer gene 1 changes. Testing guides options. Work with your clinician to personalize care. These labels show biology, not destiny. They help match therapies to targets for you. Ductal carcinoma in situ stays within ducts. No invasion. Invasive carcinoma breaks the basement membrane and can spread to nodes or beyond. Workup and treatment differ. Hallmarks of cancer in brief. 1. Growth signals stay on. 2. Breaks are ignored. 3. Cells avoid death. 4. Endless dividing. 5. New blood vessels form. 6. Invade nearby tissue and can spread. Each hallmark is a possible drug target. Example: blocking the human epidermal growth factor receptor family slows growth signals. Anti-angiogenic drugs target vascular endothelial growth factor to reduce new vessel growth. Cyclin-dependent kinase 4 and 6 inhibitors slow the cell cycle. They are used in many hormone receptor-positive cases. Care is often blended. Medicines, surgery, and radiation are combined to fit the person. Breast cancer gene 1 and breast cancer gene 2 protect DNA. They fix broken DNA using accurate copy and paste repair, called homologous recombination. When these genes work, cells keep their instructions stable. When a breast cancer gene is faulty, repair falters. Instability rises. Lifetime risk increases. Risk is real but manageable. Screening, prevention, and tailored therapy improve outcomes. Poly-ADP ribose polymerase enzymes fix single-strand DNA breaks during copying. Poly-ADP ribose polymerase inhibitors block that backup path, so the small breaks remain. In cells already missing breast cancer gene repair, those breaks pile up. The copy forks collapse into double-strand breaks. This is synthetic lethal iht. Tumor cells die while most normal cells are spared. Not all triple-negative tumors have breast cancer gene loss. Testing finds who may benefit from poly-ADP ribose polymerase inhibitors. Your plan depends on your biology and your goals. Across subtypes, teams blend targeted drugs, chemotherapy, surgery, and radiation to fit the person. Discuss options with your clinician. Biology guides. Your goals matter. Imaging, biomarkers, and genetics refine risk. They also track response over time. Knowledge supports calm care. Steady, timely checks help decisions. Simple cues to remember: subtype, hallmarks, repair status, and therapy match. Next, we see how research and diagnostics sharpen these tools. From scans to blood tests to genes, the toolbox grows more precise each year. Healthy routines still matter. Sleep, movement, and nutrition support biology. Up next, research and diagnostics, how labs and clinics work together to guide care. Up next, the dynamic duct, benign tissue-level changes you may hear about. Duct ectasia means a duct widens. Secretions can pool. The area gets inflamed around the duct. Periductal mastitis may be sterile or due to anaerobic germs. Repeated cycles can cause scarring and a slit-like nipple pull-in. The breast microbiome is not sterile. In cancer tissue, shifts appear, like lower methylobacterium, an active area of research. Next video will change how you think. Quick, clear steps you can use. We reveal powerful screening, smart targeted treatments, easy daily habits, and warning signs you must not ignore. Don't miss it, and small risks can hide. Be there. Part 2 is unmissable. Subscribe and turn on alerts now. Thank you for watching. See you next video.